Good evening, good afternoon, good morning to you all, depending on where in the world you're joining from. My name is Anne Musuva, and I'm a director with ThinkWell. I'll be your host for this Counterpoint webinar. Let me start by thanking you all for joining us today for our webinar on Kenya's UHC journey. As you all know, UHCs are the center of the 2030 Sustainable Development Goals. Achieving UHC is a key agenda for the Kenya government. And many of us who work in health financing policy in Kenya or track it closely know that the past decade has been quite eventful. In 2013, Kenya embarked on an ambitious transition to a devolved system of government. And health was one of the main sectors where significant decision-making and management was shifted to the newly formed county governments. At the same time, the government introduced far-reaching user fee removal policies for high-priority maternal health services and primary care services. In 2015, the National Health Insurance Fund expanded its benefit package to outpatient services and introduced capitation as a provider payment mechanism for outpatient services. In 2021, just 2 years ago, the government launched a comprehensive UHC program that centers around expanding health insurance coverage to the poor through the National Health Insurance Fund, which is one of Africa's longest-serving government-owned health insurance agencies. But despite all this progress, coverage with the National Health Insurance Fund has remained low at about 24% of Kenya's population. And it's estimated that over 1 million Kenyans are pushed into poverty each year because of catastrophic health costs. Health financing has been focused largely on secondary and tertiary care, neglecting primary health care, where the majority of Kenyans would access services. In early September, just last month, the government put forth 4 new health bills. 3 focused on health financing reforms. And these are all aimed at moving the country closer to the goals of universal health coverage. Among these 4 bills is a social health insurance bill, which proposes to extend health insurance to all Kenyans based on member contributions and government subsidizing coverage for the poor. It also mandates the creation of 3 funds to cover different types of services and a new government agency to manage it all. In essence, repealing the National Health Insurance Fund as we know it. If passed, these bills will set into motion far-reaching reforms on how health services are financed and delivered in Kenya. It's therefore against this backdrop that we gather here today at this Counterpoint webinar to talk about what the Social Health Insurance Bill aims to do, why and how it's going to be implemented, and what are its implications for the country's UHC plans. What is Counterpoint? Counterpoint is ThinkWell's signature series of webinars, which offers a platform for free and frank debate about questions related to health system strengthening. Through these honest discussions, we strive to both challenge dominant paradigms and scrutinize new trends to ascertain their merit. And that's what we plan to do in this Counterpoint webinar today. I am delighted to host this important discussion about the evolution of health financing reforms for universal health coverage in Kenya. We have a terrific lineup of speakers who are all at the forefront of shaping health financing policy and implementation in Kenya. I'll go ahead and introduce them without further ado. First up, we have Dr. Daniel Mwai, who will tell us more about the vision of the Social Health Insurance Bill and its evolution, and is one of the architects of this bill. Dr. Mwai is the President's advisor on health standards at the Office of the President. He's a health financing specialist and a lecturer of health economics at the University of Nairobi. He holds a PhD in health and environmental economics from the University of Nairobi. As I mentioned earlier, Kenya embarked on this UAT program to expand NHIF coverage to the poor. And lessons from that previous program will be critical in informing the rollout of the reforms envisioned in this SHI bill. Who better to be with us this afternoon than Dr. Elizabeth Wangia? Dr. Wangia is the Director of Health Financing at the Ministry of Health, and she is spearheading the health financing reforms. She was previously the head of Kenya's UHC Secretariat that has been tasked with driving UHC reforms. Dr. Wangia is a public health specialist and an alumnus of the International Program in Public Health Leadership, and she serves on the Scientific Council of the Global Burden of Disease Study. We said earlier that health is devolved, and we therefore are very pleased to have with us Dr. Joy Mugambi, who will offer us a county perspective on the SHI bill. Counties are responsible for managing and financing primary and secondary care. The implementation of the financing reforms envisioned in the Social Health Insurance Bill will be dependent on the actions of county governments. We are therefore extremely lucky to have with us Dr. Joy, who joins us from Nakuru County, where she's a County Director of Health Administration and Planning. Dr. Joy is a family physician who has pioneered primary healthcare reforms in Nakuru County, and she also wears many hats. She's the Vice President of the Commonwealth Medical Association and the President of the Kenya Association of Family Physicians. She serves on many boards, including the Kenya Health Human Resource Advisory Council, the African Primary Healthcare and Family Medicine Journal Editorial Board. Last but not least, we'll hear from Mr. Felix Murira. Felix is ThinkWell's Country Program Manager in Kenya. He leads ThinkWell's work in providing technical support to counties and the Ministry of Health in implementing various health financing reforms. We will start off with Dr. Mwai, who will give us a brief overview of the Social Health Insurance Bill, in essence, unpacking what the bill is all about. We will then have a discussion with our panelists about the bill. I'd like to encourage us to please post our questions in the Q&A section and post any general comments you have about the bill or about health financing reforms in Kenya in the chat section. Our panelists have agreed to respond to some of your questions in real time. And my colleague Felix, who is also a panelist, will also select some questions from the chat, from the Q&A section, to pose to the panelists, for what I'm hoping will be a lively and insightful discussion after the formal panel session. And at the very end, I will summarize the main discussion points and conclusions from our webinar today. And so without further ado, let me turn over the mic to Dr. Mwai, who will give us an overview of the SHI bill. Over to you, Dr. Mwai. Dr. Mwai, you're muted. Please unmute.
Thank you very much, Anne. I am hoping that I'm well audible. Good morning and good evening, everyone. So as highlighted, I think my work is easiest in this presentation is just to highlight the key issues that pertains to the new registrations that are in the House as of now. And I want to first highlight that within the Kenya UHC agenda, the government has prioritized largely 4 areas of investments that are critical in unlocking the UHC agenda. The first one relates to commodity security. The second relates to human resource for health. The third relates to the integrated health information management system. And the last one is about healthcare financing. Key among them is the UHC model that is primary healthcare driven, with the DNA being the fact that the desire is to provide services closer to the people. And in that provision, then the financing become important as the source of inputs that are supposed to provide healthcare services. Now, within our healthcare financing model, we find that Kenya would want to explore a quasi-output-based kind of financing, with the Social Health Authority becoming the key strategic purchaser of healthcare services across the healthcare facilities. That is from level 2. This is dispensary health centers, all the way to the referral centers, facilities, which in this country we call level 6. So ideally, the Kenyan healthcare financing landscape is characterized by huge out-of-pocket expenditure, just as many countries within the sub-Saharan Africa, so to speak. And the issue also that is critical is, the structure of the economy being largely informal, with 80% of Kenyans, having been, operating without a payroll. And these non-payroll people are the majority, and of course need to be catered for. Needless to mention the issue of poverty, of course, that we have 3.5 to almost 4 million households that cannot be able to pay for their social health insurances. And therefore, this bill comes in to solve the issues pertaining to the issue of governance around the financing, the collection of revenue that is needed, the pooling of risk, as well as the strategic purchasing of healthcare services within our country. So those are the main. So again, our country service delivery model is from level 1, which is community healthcare service, which is largely funded by government through the provision of inputs, that is community health promoters, kits, as well as the stipends, as well as other, equipments, basic equipments that they require to provide their care. Then the Social Health Authority bill, beginning from level 2, where we have primary healthcare services, we go to primary and secondary referral. These are sub-regional facilities, and then we go to tertiary referral. So that is where the bill is talking about, coming into force to provide the legal infrastructure or framework to be able to fund healthcare. So with that, I would just highlight that we have a Social Health Authority that will operate 3 funds. The first fund that is government funded is for primary healthcare services. The second one is a fund that is contributory, which is a social health insurance that kicks in as a referral from the primary level. And the third one is what is called the chronic illness and emergency fund. And this kicks in for diseases that are, for costs that are beyond what is covered with the social insurance, but also kicks in to shield the households in case they have an emergency, and that emergency might require, stabilization as well as ambulance evacuation. So that is covered within the 3 funds that you find within the Social Health Authority as captured within the bill. So this bill has not been made, not only, based on, wishes or such. It is based on extensive work that have gone into the past that, is already well documented within the Universal Health Policy of 2022. We also have the healthcare financing strategy, and we also have the manifesto of the current government, which ideally is, following closely to want to provide quality care for all Kenyans in a way that they can guarantee the highest standards of care for Kenyans going to the future. It's also bringing reform within the current National Health Insurance Fund, which is our current quasi-social insurance fund that we have, which ideally has been doing everything. It is the one that, determine the premium, determine the package, determine who it will pay, pays them, do dispute resolution, does not have tariffs, and many other such issues that are, have made it a little bit difficult to be able to scale up the penetration of the social insurance. So that is another issue that need to be taken care of. So in that, then the new bill brings on board products that is social health insurance compliant, again tackling the intention of having more than 80% of the non-employed, and more importantly, based on actuarial calculations that not only project the burden, but also the package that are supposed to be provided. Largely does not have enhanced schemes. Tames the issue of efficiency in administration of funds, fully digitized, so to speak, and that aligns to the other bill on digitization, reduction of wastage and leveraging on the existing innovations in technology to reduce for that, moving from passive to strategic purchasing. These are some of the key things that this bill is actually proposing to bring on focus. So I would want to pause there because I think the time would be more devoted. The bills are already available for interrogation and review, and we'll be happy to spend more time engaging on how to make an idea that is good more better. Thank you.
Thank you very much, Dr. Mwai, for that really comprehensive overview of the social health insurance bill. I just want to pass over the mic to you, Dr. Wangia. So we've heard from Dr. Mwai, but in a nutshell, in your own words, what problem are we trying to solve? What is not working with the current National Health Insurance Fund that the Social Health Authority will fix? Dr. Wangia.
So thank you very much, Dr. Ann. Just to pick up from Dr. Mwai's submissions, that first of all, we know that the NHIF Act is one of the 60s. It was amended in 2022 and currently also undergoing some regulations. And some changes have happened based on inputs from experts who gave some key recommendations on how the NHIF by then would work best. And even following the recommendations, we still saw quite a number of gaps that we thought that this time a new entity. So to start with, we look at the governance structure, specifically looking at the governance structure of the current social health insurance bill as it is. We are looking at mainly the board composition. And when we look at the board composition, we are mainly we mainly focus on professionalism and not just representation. So in as much as, yes, we could look at representation, but within the representation, we are looking at what qualifications exist, because we believe that a strong governance structure is key to any success, the success of any institution. In addition to that, a number of issues also were raised by Dr. Mwai, touching on the many functions that NHIF is undertaking, right from registration of members, collection of the resources, determination of the tariffs, dispute resolution, empanelment of facilities, and all these are more or less would more or less serve as conflicts of interest. So with the new bill, we are looking at separating some key functions. Number one key function is dispute resolution. We are bringing in a tribunal which is independent, an independent entity that will be appointed by the cabinet secretary that will look into any disputes that will arise and try and resolve these disputes. The second thing is mainly on empanelment of accreditation, certification, and empanelment of health facilities. We believe that that there should be an independent institution that should be mandated to do that work, whose core mandate is quality assurance and the quality assurance. So with that, this bill proposes that there will be an independent, information from this independent institution is what will be used to determine which facility should be actually empaneled within the fund. In addition to that, we are looking at not only including health facilities, but also capturing health providers, because there are situations where we know that providers should be, maybe it's, for instance, an independent provider with, their own consultancy firm, or even when you look at things like telemedicine. With this, it actually provides for reimbursement of a provider, even if it's through, say, telemedicine, and this is what you call the digital kiosks. In addition to that, just looking at increasing the efficiency of service delivery by mainly focusing on digitization. We want an end-to-end digital fund, a digital system where we try as much as possible to reduce almost to zero the human interface when it comes to operations. And this will not only increase efficiency, but it will also enhance accountability. And finally, on that, we know that we have had quite a number of schemes, of which these schemes are having high administrative costs. Some of the schemes eat into other schemes instead of a specific scheme focusing on the people covered. And with that, we are seeing that with only focusing on this one scheme, which is which will be the social health insurance, within the social health insurance fund, then even the admin costs will be low. And therefore, we are committing within the bill that admin costs will be maintained at less than 5%. 5% or less. And sorry, finally, in terms of claims management, we're also saying that yes, the claims will be managed independently. And this is more or less because we know this is quite, first of all, it's the core when it comes to service delivery. And this with these claims bodies that we are proposing, as it is, we don't believe that one entity would have the capacity to manage all the claims, given that we are seeing that these claims would be even to the tune of probably 200 billion Kenya shillings eventually. And that's, we are saying, for proper management of the claims, then we need, independent institutions to manage the claim. And all these are following recommendations from experts based on a report that was provided to the government. And most of the considerations captured in this bill are actually from experts, opinions. Thank you.
Thank you very much, Dr. Wange. I think one of the things you mentioned that will resonate very well with Kenyans is capping the administration costs for the Social Health Authority at 5%. I'm seeing quite a number of questions and comments trickling in the chat, which is fantastic. Please keep those coming. To our panelists, please feel free to respond to some of the questions in the chat. And at the very end, we'll consolidate some and have Felix post them. So please keep the questions coming. Now, Dr. Moi, you talked about the fact that part of the contributions will be contributory. You are a big bulk of them for the Social Health Insurance Fund. Why has Kenya chosen to move ahead with a contributory mechanism? Several papers have been published questioning the sense behind chasing contributions from the informal sector, who comprise 80% of Kenya's population. So why is Kenya opting for this? And do you think we will succeed where others have failed? Over to you, Dr. Moi.
Thank you very much. I think two things. One is that if you look at the Social Health Authority bill, it's not talking about a contributory mechanism, but it is using a mixed approach in financing of healthcare. Because when you look at the primary healthcare level, it is financed directly by government, and therefore it's not a contributory mechanism. And still, it will be used to provide, up to, where we have an average, or we would think that it would have a burden of 60 to 70% of the communicable, diseases. The second thing I want to highlight is the fact that on the issue of the social insurance, which is contributory, I want to first highlight that Kenya has never failed because it have never tried. We have always come up with social health, quasi social health insurance product that are centered on the 20% of Kenyans who are employed. And that is why even the discussion now, you try to skew it towards the informal and unemployed, we still get, even technical people taking us back to the 20% that are supposed to be contributing, despite the fact that the social authority is largely not really, using the majority as the informal, as the formal, rather than the informal. Now, with that, then it becomes important that within the regulations to these bills, there is need to detail the opportunities to actually make the mandatory, because what we have done in the past is to have a law that is not about mandatory, but for the informal, we actually call it voluntary. So the more it becomes, mandatory, the more it remains voluntary. That's the real thing, and therefore we suffer the issues of adverse selections, and we find that the pool for the informal, which is actually voluntary, absorbs around 291%, so to speak, because of adverse selection. But when you look at the bill, there are measures that have been put in there, ability to capture the informal sector, where they go, where do they go, who do they associate with, how do we enforce the payment of the same. You see the issues of premium financing, aligning the, the ability of voluntary contributors to remove the issue of adverse selections when they are paying for this. So I would say this, and just to the interest of time, is that when the regulations are actually published and clearly laid out in detail on how to deal with the mandatory contribution component of the social health authority, then we will be able to outline in detail where do we capture or how do we make it mandatory for the non-payroll people to actually, pay, because that is the only thing that we need to deal with. Otherwise, if it has been working for the payroll because they are identifiable and they can be seen, then it means that we should, as a country, move away from the thinking that we are a largely formal system to the informal system and come up with the solutions that address our healthcare financing given our context.
Thank you. Thank you very much, Dr. Mwai. So you've talked about the fact that we need to move from just focusing on the formal sector to also capture the contributions from the informal sector. The SHI bill proposes means testing as a way of finding the poor, deciding what rate the informal sector will pay, and so on. This is quite expensive and complex. Dr. Wangia, why would you want to do this? And can you talk a little bit more about how this means testing will be implemented?
Thank you so much, Anne, for that question. And basically, yes, as indicated, that we need to have a way of identifying the poor, first of all, the poor and the people within the informal sector, because we are able to get the resources or the premiums from the formal sector because we know where they are, we know how to get them. So for the informal sector, we are looking at how do we get the informal sector people. And mainly, most of them would either be doing businesses. Not all informal sector, not all the informal sector, people are poor. So they are running a business, or they are somehow seeking some government service. So from our end, we are looking at these avenues and specifically focusing on really how do we enforce this. And we'll really target them, especially in seeking government services, licensing, probably school enrollment, and all this will be captured within the regulations. And of course, together with the enforcing measures. Then once you have identified them, it will be critical to get to know approximately how much do they earn, even based on the businesses. And we have quite a number of algorithms we use to really get to estimate how much people will be paying. And based on this, it won't be a flat figure like the NHIF, where for the informal sector, it was a clear 500 shillings, because even that 500 shillings was not based on science. So we know what the package will cost. We have costed the benefits package, right from the primary health services to social, what will be offered at secondary level, and even emergency services. We know the cost of the package. And based on that, we know approximately how much ideally people should pay. And with that, we really, in the spirit of, equity, the contributions will be graduated based on, just as it happens within the formal sector. Within the formal sector, the least paying person within the formal sector pays around 300 shillings, while the highest paying is around 1,700. And this is the same method that would be used based on people's income, based on the algorithms that we are using. So we are seeing this as a clear pathway that will at least get to know how much each individual will pay. And we are saying, since we don't want to keep on getting to looking for the individual each and every month, we are proposing that for every individual, once we find out that your premium is, say, 700 shillings, then you pay an annual fee. Once you're paid the annual fee, if you don't have the resources, then there are opportunities for premium financing, where you can borrow the resources from either the Hustler Fund, the cooperatives. We have seen quite a number of initiatives, like through the cooperatives, the milk cooperatives, tea cooperatives. You can borrow, pay for your insurance, then pay slowly at very slow, low interest rates. And that's how we are seeing this method taking shape. And of course, every year then we may have to either reassess, and we would also want people to also declare and say that this is what we have. Of course, based on that also, we'll do the checks and find out per household what is the contribution level for a household, and we'll subject that to an agreed upon percentage to determine the contribution for the household.
Thank you, Dr. Wangia. Yeah. I think that's really interesting. Certainly will be a first for this country. Dr. Joy, the counties are really the front lines. You are really at the front line of providing services for the people of Nakuru County. Is this social health insurance what the counties need? Do you think this is really what will help sort out some of the issues that have been plaguing counties for the past, since devolution? Dr. Joy.
Thank you very much, Anne, for this invite. And sure enough, when we talk about the social health insurance, having been broken down into three key areas, the primary health care, the indigents, and now the chronic care and emergency care, counties need this. Why do we need this? One, we are in the journey of self-reliance. Primary health care has been highly funded by the donors, and we are now embarking on ensuring we fund primary health care as devolved functions and ensuring that we provide the best at the primary health care level. Having a primary health care fund will ensure we sustain the services that we offer, and we ensure they are quality. Looking at the indigents, we tried out what was being offered by NHIF. And sure enough, yes, we needed a better structured system to ensure the most poor are getting health services of high quality as a human right. And with this fund, we do envision having better systems to ensure that they get the best in terms of healthcare. Come to chronic care. Every family, every home has a patient who is receiving chronic care services, but it's quite expensive. If you look into your WhatsApp, today you have contributed to someone's Harambee, either for their chronic care services or an emergency that happened, they are going in for an orthopedic surgery. They require quite a lot in terms of funding, but a lot of man-hours are lost. Nakuru County has been one of the hardest hit when it comes to road traffic accidents, and reimbursement of those services is really poor. But if we do have a chronic illness and emergency fund, this will ensure that we are well funded and we can as well improve our services in terms of emergency response whenever we have one within the community. So yes, the social health insurance fund is really key for us. Breaking it down into the three portions in terms of primary health care, indigent, and the chronic care caters for both primary, secondary health care, and those who are not well endowed to be able to cater for their health services. So thanks, Anne.
Thank you, Dr. Joy. What I'm hearing from you is that you're excited to see this primary healthcare fund and this critical care fund, which addresses some of the challenges that we've been facing in the country, right? If you open the newspaper on any particular day in Kenya, I think what you'll see is that the Kenya economy is really under pressure. Some Kenyans might say it's under siege. Now, we have high inflation levels. We are servicing all these debts. With this SHI bill, the government is proposing to cover the poor and also to subsidize the informal sector, at least partially. So far, Kenya has covered about 1 million poor households. But we know there are still at least another 3-4 million poor households. How does the government plan to finance the SHI bill and especially the poor? Where will this money come from, Dr. Mwai?
Thank you very much. At least from where I look at it as an economist, money is never enough. And, one thing that happens within an economy is that as different, as the economy grow and it generates more income, just the same way an individual become, more richer in terms of incomes as they grow, then they are able to shoulder bigger responsibilities in terms of financings. So now within our constrained fiscal space, the expectation is that we want to identify what we would call the real indigents, which ideally these are people who have a very low ability to pay. But we also have people with low ability to pay who can pay something. And that is why we want to identify these ones. And someone would ask, why then are we going through the contributory mechanism? Is because the tax-based systems are largely, inflationary if they were to target the masses for contributions. So you'd see that there is reservations towards, altering the market in terms of introducing other taxations or targeting, for this kind of purpose. But having said that, is that you have seen that despite the challenges we have had, is that this government has been able to increase the funding and allocate resources for the community health promoters who were not in the previous budget. And therefore, while we talk about the issue of fiscal space and availability, there is also an issue of prioritization on where the country wants to put its resources. And we believe that when you look at the return to investments for health, they are far much higher than many other investment areas that the countries have been putting in. So the desire of this government is to generally prioritize, the social health or health benefits, so to speak, because a health population is the base for production. And therefore, it is with great priority that you have seen the current shifting of funding to prioritize the community health promotion level, which is the community service level of service delivery. And as we move towards the second tier, as well as the social insurance, which will require such a level of subsidization for those who cannot afford, expectation is that the government will prioritize these areas so that despite the challenges in the fiscal space, we'll still be able to cover for the 3.5 million households or so that require to be covered. And those who can pay, then they are able to contribute based on our ability to pay where those who, have less money, contribute less in terms of value, but proportionately, we should all be, contributing the same. Needless to mention to you, Anne, that the current system is regressive. And this is where you find that the current NHIF, if you are earning around 10,000, you will be contributing approximately 5% of your income. But in the same country, if you are earning $1 million, your contribution will be at 0.017%. So it's an issue of also bringing equity and leveling the ground, so that those who can pay. Those the government is supposed to subsidize. And then we have a package of care that we can all, be happy for as a country. Thank you.
Thank you, Dr. Moya. I saw you smiling. I don't know if it's because, you didn't really tell us where the money will come from. But one thing we can certainly agree on is that the current contribution mechanism is regressive. Dr. Wangia, we spoke about the 3 funds that will form this social health authority. What drove the specific design choices? What's the thinking behind having these 3 separate funds instead of one big fund, for example?
Yes, and thank you, Anne. So we need to really be focused. We know that, first of all, with the current government, we are really focusing on achieving UHC through a primary healthcare approach. And this is not just a country priority, but it's a global general direction, which of course has been seen to have a high return on investment. And therefore, that really catered for the main reason why we at least had the primary healthcare fund, so that it can cater for the primary health services, which are largely close to 90% of the services the citizens actually need. And catering for these primary healthcare services would actually ensure equity, I would say so, because most people at least will end up seeking the primary level services. So for the sake of having a clear focus on really financing this level and committing to this financing, then we had the primary healthcare fund. And we also know that, yes, in as much as we are also focusing on moving away from donors, but before they move completely or partially, we may find that there are actually people who would really like to support primary healthcare initiatives. As it is right now, there are so many primary health initiatives, primary health initiatives from different sources. And we are seeing the end game of this being that all at the end of the day, all these resources will be pulled together, and therefore we'll be able to buy proper, pull all these resources and be able to strategically, purchase primary healthcare services. When it comes to, allow me to move to the emergency and chronic and critical illness fund. The emergency care is actually catered for in the Constitution, that we need to provide not only the highest attainable standard of healthcare, but also that no Kenyan will be denied emergency care. But in the process of not, claiming so within the Constitution, there is really nothing much or not much effort that has been put even by previous governments to ensure that this constitutional right is actually met. So with that, we say that in order to cater for emergency care, because you never know when you'll need this care, then, and this is also captured within our Health Act, therefore the need for the emergency fund. So this fund also rides onto the chronic and critical illness fund. And it's based on the fact that we want to manage outcomes and not just necessarily, incidences of care, because we have seen situations, especially for patients with chronic illnesses, where, say, those who are covered by NHIF to a certain limit could actually stop their care once that limit was exhausted. And for instance, if it's cancer and you are due for, say 10 cycles, and your cover can only cater for 6 cycles, we could see a lot of patients stopping at the 6 and waiting for their next year so that they continue. And at the end of the day, you realize that even the 6 cycles were in vain, because then the patient's condition actually goes becomes probably worse than it was before. So we are looking at this as an avenue to have, you know, the continuum of care, right, from the primary health services to, you know, the services at secondary level, and to additional services if need be. And when we are looking at this chronic disease, I know there have been many questions as to whether all chronic diseases will be catered for within this fund. What we are seeing as the target for these chronic diseases are mainly the diseases that the conditions that are over and above what will be covered within the SHI. So the SHI is, for the chronic disease, the SHI is actually the base. So when you have the SHI, you exhaust your limit within the SHI, then automatically you get into the chronic disease fund. So to the patient, you may not see this happening because you'll get the continuum of care will be clear. But then at the back end, we'll know that that you have exhausted your SHI, and therefore you are now dipping into the chronic disease fund. And the same happens to critical illnesses, like in cases of say ICU care beyond what will be covered within the social health insurance. And since most of the chronic and critical, especially the chronic illnesses fund, and mainly we know that most of the not all chronic illnesses are non-communicable. Not all chronic illnesses are non-communicable diseases, but largely most non-communicable diseases end up being chronic. And therefore, even when it comes to looking for the resources, we can actually target the risk factors to non-communicable diseases as potential sources of funding to this particular fund. So it's based on that we saw the need to clearly separate this fund, because, you know, even for the chronic disease fund, you can't really call it an insurance as such, because it's a sick fund. It's definite that once you get into the fund, there is no risk sharing. There is no, you are sick. There is no well person catering for you. And therefore, and that's why we are committing that this particular fund will be publicly financed and not, not contributory like the social health insurance, where you are looking at, looking at the risk, the potential, risk pooling, so to speak.
Thank you, Dr. Wangia. I'd like to encourage us to continue posting our questions and comments on the chat, and to our panelists to please respond to them in real time. We will have some time to pose some of the questions in the chat to the panelists, but certainly not all. So please respond as we go along. Felix, ThinkWell works across a number of other countries and also works to generate evidence to inform UHC reforms. What do we know from other countries about implementation of similar reforms on social health insurance? What has worked and what hasn't? Over to you, Felix.
Thank you, Dr. Ann, for that question. I think from the discussion that far is that the source for the money is a big problem. So there are many lessons that we can pick from the low and middle income countries on the experiences on implementing social insurance schemes. And definitely one of those that I would like to focus on right now is revenue raising. Moi has mentioned that the new social insurance bill proposes mandatory contributions from more Kenyans, including those in the informal sector based on the ability to pay using means testing. This is good. However, the NHIF Act of 1998, for example, and even the attendant amendments, including the most recent one of 2022, maintained the same mandatory contribution requirement. While this has been working well with the formal sector, it has been challenging to collect premiums from the informal sector, which Dr. Moi has also mentioned, constitute over 80% of the Kenyan labor market. Evidence has shown from other countries in our context, while enrollment and contributions could be mandatory in law and in policy, in most countries, it has been problematic and difficult to implement in practice, often resulting in poor population coverage, low retention rates, and even advanced selection, which further entrenches inequalities, inefficiencies, and even problems of financial sustainability, which I think has been mentioned as part of the problems the new social health insurance bill intends to solve. We have seen countries like Ghana, for example, and Gabon, which have comparatively higher social health insurance coverage, are often characterized by tax-based revenue raising and less contributory mechanisms, whether mandatory or not, which other countries mostly did not employ. Literature has also shown that the enrollment in social health insurance schemes has been correlated with ability to pay. And you have had Dr. Moi mentioning that the payment will be based on means testing results to determine how much households can pay. It goes then that access to benefits is based on contributions. And evidence is showing that consequently, there is movement towards selecting higher socioeconomic individuals, further promoting inequity. I do think that as the country moves towards implementing the new social health insurance bill and implementing a raft of changes, and this being the very first time that we have seen the government taking deliberate decisions to actually enforce mandatory payments, to pick lessons from these countries so that policymakers, advisors, and other people within the space for implementing government policy on health will have to contend with these issues about ensuring that we can finance sustainably the social health insurance scheme. And also the design that we come with is able to mitigate the consequences that I've just mentioned to improve population coverage, service offering, and to promote quality and equity. Thank you, Dr. Han.
Thank you, Felix. I think you're still raising some really critical issues around the feasibility of collecting these funds from the informal sector. And I hope we'll get more clarity as we move ahead. Dr. Wangia, we know currently that the National Health Insurance Fund currently manages over 70 schemes, I believe. Some of these include the Linda Mama Free Maternity Program, which is a universal entitlement that has been lauded for increasing access to maternal and child health services. How do you sustain these gains, especially during the transition from the current NHIF as we know it to this social health insurance, so that the benefits that mothers have been receiving, do not go down the drain? And I'm seeing also that's one of the questions that's coming up in the chat. Dr. Wangia.
Okay, so thank you so much, Anne. As you correctly say that most of these schemes were mainly to serve a specific function. For instance, as you correctly say, the Linda Mama was targeting, the health of the mother, pregnant mother, plus the child, up to around a year old. We have even the Eduafia, which was targeting, the students, the learners in primarily high school. And we are saying that as we transition, we will have to consolidate these schemes, but we need to get to a point where we have enrolled a critical mass of households into the social health insurance. Because remember, this mother, who, when we pay for the mother, the Linda Mama, it's only the mother covered. And once she's done with the delivery and the child is close to a year old, she no longer has a cover, which is, yes, it met the need, but then it's not sustainable. But we are saying if, when households enroll into the social health insurance, it's not only the mother. This household will have a student or a learner in school. They'll have the father is within the home. So basically the entire household will be covered. So yes, as you correctly said, during the transition, we may have to stagger, stagger the the cover, but eventually, as we get into a critical mass of people enrolling within the social health insurance, of which our target is 85%, then we can confidently say that within this 85%, if there is a pregnant mother, she will be covered. If there is a learner, the learner will be covered. And therefore, all these resources will be brought together and be used to cater for the indigents, because these are government resources. You correctly say that currently we are covering close to 1.2 million indigents. If you look at the indigents, the poor and together with the poor and vulnerable combined, they're around 1.2 million households. But we have around 5 million poor households. So as we get more and people on board, as we lose this money that we were initially catering for Linda Mama and Edu Afya, we'll be able to cater for the additional households who really, really need this support, financial support.
Thank you, Dr. Wangia. I believe what you're saying is that there'll be a sort of phased transition so that we don't, if the bill is launched today, for example, on 20th October, for example, 21st won't have the Linda Mama program disappear and mothers not able to access services. I think that's welcome news to many of us. Now, Dr. Joy, since the Linda Mama Free Maternity program was rolled out in 2017, basically how it worked was that mothers would access services from both public and private facilities, and facilities would then be expected to claim reimbursements for offering these services to the NHIF. Now, to date, in our experience as ThinkWell, we've seen many counties where facilities have never sent a claim to NHIF despite offering services, and therefore missing out on much needed revenue to improve services. Do you anticipate a situation where in 2030, we still have facilities that have never submitted an SHI claim to NHIF? And how are counties preparing to tap into the resources from the new SHI funding mechanism? Dr. Joy.
Thank you very much, Anne, for that question. Yes, a number of facilities have not had the opportunity to claim within Linda Mama. One has been a lot of facilities are under primary health care, and the infrastructure for NHIF really did not cater for primary health claiming facility. But looking at the SHI, we see an opportunity for primary health care providers to be able to claim. We've heard from Wangia saying that healthcare providers will also be able to register and be able to claim from the social health insurance. If I am a private practitioner with a clinic, I'll be able to claim and be able to provide services to the ones who need it from my service provision point. In addition, we've had challenges of infrastructure to be able to claim. Computers, internet access in some of the rural remote areas where these primary healthcare facilities are embedded has been a big challenge. And this is one thing we need to look at. Is there a way of ensuring we have enough internet access in these facilities? Can we simply use a phone to make claims rather than a whole computer with all the expensive gadgets that need to accompany it? Registration processes also for some of these facilities was a challenge. Remember, these primary healthcare facilities were offering free service and were not generating any revenue to be able to procure and maintain these gadgets that are required to make the claims. So we hope that with this new insurance cover, the electronic medical records and the claiming system will be simplified, even in a way that I can do it seamlessly on a phone without having to use a lot of even papers. We are trying to cater for climate change, but then it's too much. We hope that that will also be mitigated as we move on into the SHI fund. Thank you.
I think those are really important considerations you raised there, Dr. Joy, around reducing the paper burden that goes with just submitting a claim to NHIF. And I hope and trust that these are some of the changes and reforms that we will see moving forward. Dr. Wangia, what are some of the biggest hurdles we can expect on the way to implementing this bill, and how do you plan to navigate them? I'll just ask you to make your response very brief, because I'd like to hand over to Felix very soon to see what sort of questions we are getting in the chat. Dr. Wangia.
Yeah, so just to pick up from Joy's comment is that as it is still at primary level, we are not fully digitized. We know that the community health level is digitized through the electronic community health information system. There's digitization at the most secondary level facilities, but at the primary level facilities where we intend on supporting through the primary healthcare fund, we don't have much of digitization, and as much as we could get user-friendly apps that could you could just use a phone. We know also capacity, there are different capacities at the different levels. We have close to 9,000 health facilities at that level. So that is one hurdle that we know that we have and that we are really cognizant of. And that's why, as part of the priorities within the UHC priorities are around digitization and just boosting the infrastructure. The other thing that also we saw in the previous UHC initiatives is the health-seeking behaviors. Every time there's something new, everyone wants to try it out, and therefore we know that initially that there'll be a high access to service, and it's not a hurdle as such, but we know that during this time, probably if there are any teething problems, it could seem like it's discouraging or excessive services will be sought, and probably at that point in time, even the facilities may not be ready for that, because it will take time for them to claim their resources, for them now to improve their services. So we are that is the main hurdle I'm seeing moving forward. Otherwise, the other thing I would just talk about, given that most of our services, will be digitized. Therefore, we know that we will require less and less of human resource, and therefore just seeing how to balance all that with the previous human resource that were there within who will be transitioning into the fund, and given that this time we will need quite fewer human resource. And with that, we may just need to see how we can also handle that challenge.
Thank you, Dr. Wange. Indeed, digitalization will be critical for these reforms moving forward. Dr. Mwai, I think we're all curious, what sort of changes can we expect to see in terms of the provider payment mechanisms for these three funds and the benefit package? Are there any additional goodies coming along? Dr. Mwai.
Thank you very much, Anne. And I begin by saying that, of course, every time I keep a smiley face, because I do believe that we must motivate ourselves within the journey. Now, having said that, I want to highlight that just as Felix highlighted, please, if I may, in some few seconds, highlight that well, we have looked at the systems that are landing within the Ghana and Gabon with the inability to mobilize enough resources actually to shoulder the healthcare cost and burden. The model that is suggested is a mix, as I highlighted, of tax-based system as well as the contributory system. And I think it's good for for all of us to actually take some time and really, look at how that comes to mix, so that it's able to not only mobilize the resources, but also really for sure, be able to finance the package there. So there have been efforts that are going on currently. Of course, the bill is in front, and other work is continuing. And the work is ideally to come up with the essential benefit package that have been highlighted, starting from the first level, which is community, coming to the primary level facilities, as well as primary and secondary referral facilities and tertiary, and the kind of services that need to be purchased from there, given the benefit package that is being developed. So this is work in progress, and it is continuing because Kenyans must know what they are entitled to. The second thing that is important is that within the social health insurance, we expect that there will be a tariff, and the tariff will be the key guide on what you are entitled to. For instance, if for example purposes, a normal delivery is costing 80,000, and that is a tariff through which the social insurer is paying at, and you find yourself going to a higher level facilities, for instance, the facilities we have here that are private that will charge the same delivery for 250 shillings. Then what we say when we mention the tariff is that the social insurer becomes a fast charge, and if it's a fast charge, then it means that it will pay the facility, the hospital bill, as per the tariff that is you are entitled to. And therefore, the issue of middle class and the rich not, claiming that they are not using their social insurances will actually disappear. Now, so that is a tariff as well as the, the essential benefit of the package that is being developed and optimized. So there is work that will go into, how this will be rolled out. And again, I have highlighted that a good idea is made better. So we expect that better thoughts and contributions will actually come. Some of them from this meeting, even to make sure that we see the loopholes that ideally have made Kenya not to make big strides in terms of financing for healthcare. So I would largely say that the benefit package will be, of course, looking far much better, because the more you randomize and pool the risk of a bigger population, then you are able to cover better benefits because the risk is lower. And the issues of adverse selection are reduced, and it becomes a little bit easier to have better services for everybody. Needless to mention that the literature is clear that only 5% of populations require huge catastrophic health expenditures, and therefore the 95 should be willing to shoulder and subsidize those that are requiring. So that is a kind of discussion that is going on, and it will continue for the next few months as we also plan the roadmap on how to transition and how to roll out. But benefits will definitely be better. The contributions, of course, is based on ability to pay. That's another new thing, because it's close to your question. And this is important because we must all take charge. And we also know that we have seen people invited into hotels, and because they are not the one paying, they overconsume some food so that the other person pay. And these issues are usually addressed in unique manner in social insurances. If you may look at the literature, I'm just simplifying it for people to understand it here. And therefore, this is part of the process that will be put in place and well detailed within the regulations going forward as we move towards implementation or after the bills become law.
Thank you, Dr. Mwai. I was just laughing when you said that people overconsume food that is free in a restaurant, and reflecting whether that's peculiar Kenyan habits. Anyhow, at this point, I'd like to hand over to my colleague Felix, who will pose some of the questions that are coming, especially those that are coming up quite a bit to our panelists. Felix.
Thank you, Anne. There are a number of questions, so we'll kind of group them and ask individual panelists. And to start it off is Dr. Mwai. Rubayat Khan is asking that one thing we have learned from insurance schemes across many countries is that paying for interventions does not incentivize quality. How will the new insurance bill promote value-based care and incentivize delivery of outcomes rather than just interventions? The second question that I will pose to you comes from a gentleman called Dr. Shefand Mwandano. I'm hoping I got that right. And he's asking, and he's asking a question on equity and access. So how does the proposed social health insurance bill address issues of equity and access to healthcare services, especially for the marginalized and vulnerable populations? And are there measures in place to ensure that all Kenyans, citizens, regardless of their socioeconomic status, can benefit from the insurance scheme? I will pose the next question from the chat to Dr. Wangia. It says that some countries have experimented with earmarked funds for health. Is this something that has been considered, seeing as we have finite resources already, as we have seen we don't have finite resources, and has a costing been done for the implementation of this new proposed bill? Finally, I will pose the first piece of questions to Dr. Joy, which is counter-facing. And it is asking that we do know detention for NHIF has been the biggest challenge among Kenyans due to inadequate or lack of comprehensive services in our public sector. How do counties plan to address the same? So we start with Dr. Mwai, then Dr. Wangia will respond, and then Dr. Joy, then we take the second set of questions. Thank you.
Thank you. One of the key challenges that we have had within the current national health insurance is actually also the same issue of not really taking care of the quality part of the UHC. And I mean, this has been there for quite some time. When you look at the bill proposes the formation of the Quality of Care Authority, which ideally is supposed to guarantee that the services we are getting are of quality. And this is an authority that will talk about the accreditation, the issues of belonging to certification body or quality improvement program, the issue of incentivization for provision of quality of care. And therefore, that is already alluded to in the bill. But I want to also highlight that while we have 4 bills going, we still have some need for a registration that is coming to create the Quality of Care Authority that is supposed to make sure that quality of care is gotten. The issue of equity and access, I would highlight that we know that the split is almost half-half in terms of care services that are accessed, both public, private, and FBOs. I think we have seen that in these bills, the suggestion is not to discriminate the client from where they go to seek service, and therefore they are able to seek services and pay through the year 1 card. And that 1 card is a card that, of course, is covering the 3 funds, and therefore you don't have 3 cards that you'll be having. It's only 1 social health authority card. That card will guarantee that you can be able to access services from private, public, and FBOs, and improve access and tries to tackle the issue of inequality within the countries. The issue of the Facility Improvement Fund is also supposed to boost the ability of the public facilities that have a higher distribution in terms of them being equipped better to provide the care, and therefore increase access also to these households. So it's still a journey, so to speak, before we would have equity in access. But also the key thing is that the distance to the nearest health facility has shrunk tremendously over the last few years. And therefore, what we need to focus on is that the available facilities are able to provide the quality of care, and citizens can access it and purchase that care, and they do not incur catastrophic spending within that settings. Thank you.
Yes, so on the question on earmarking funds for health, and indeed, this is one of the avenues we know that we'd use to get the publicly, when we commit to publicly financed primary health care and the chronic and critical illness emergency fund, these are some of the areas that we may want to explore, earmarking some of the funds, looking at, we have previously earmarked tobacco, alcohol, we could go to sugar sweeteners and all those things that cause ill health, so that we increase the resources towards support for these funds. Then in terms, there was a question around costing as to whether we have done costing of services, and indeed we costed the services, and therefore that's how we determined the cost of the package, and that's even how we knew what amount of money do we need for the chronic and emergency fund, what amount do we need for the primary healthcare fund, and what amount do we need for the social health insurance. However, even a more robust costing is actually ongoing based on clinical pathways that will really get down to really tell us what will be the cost of services. So yes, costing is has been done and is still ongoing. And yes, earmarking of funds for health is an avenue for raising public resources.
Dr. Joy.
Thank you very much, Felix. In terms of service improvement, the 47 counties having been devolved have made a very big difference with their equitable fund. Funds having come down to the communities has given a voice to the communities to be able to initiate projects that they feel will make a difference within their communities, other than when they used to trickle from national government and the national government decides what you need. This time round, people are deciding what they need. Services are improving because even people are questioning what kind of services are you delivering to them? And looking at the last 5 years, I give an example of Nakuru County. There has been quite a tremendous improvement in terms of healthcare delivery. When we look at the secondary care, we now have a cancer center, a renal unit that takes up the NHIF claims. We have also the cardiology services. We have surgical services, orthopedics, that has really improved the service delivery for the people of Nakuru and the regions around. And we've seen even the private insurers claiming from the services that we have, and we have engaged a number of them for their clients to seek the cancer care services within our cancer center, our renal units, and we are able to be reimbursed from those also private care providers. So in addition, this has been critical in terms of service delivery, though now we have embarked on improving our primary healthcare service, engaging the primary healthcare networks, ensuring that the primary healthcare facilities infrastructure is improved, and they are able to claim their finances even at the very primary healthcare levels, where infrastructure, digital infrastructure is also being improved to ensure that they are reimbursed adequately as we move forward. So we look forward to the social health insurance, because some of the gaps that we have are the indigents, the street children, the older persons who are in our older persons' home and are not able to be able to cater for their own financing for health insurance. So those are key things that we look forward when we embark on this journey for SHI. Thanks.
Thank you. I know we don't have much time, but I have space to ask 3 questions that I'll direct to each of the panelists. Now, there are a number of questions on claims management and transition. And Caitlin is asking, and I think this should go to Dr. Wangia, how is the government of Kenya planning to manage the transition? How will the government protect against slowdown in NHIF processing current claims now that they are aware that they will be winding down? Sounds like there could be disturbance at the implementation level. What concerns do the panelists have for the transition in particular? And related to that is on claims management. This is a big one on what is the logic for outsourcing? How will it impact the cost? And this is Dr. Moi's question. And finally, there is a question that has been posed by, sorry, I might confirm here, on means testing. I don't see the person who asked. It's basically asking the Kenya South Bank Insurance pilot showed lots of inclusion and exclusion errors. How will the new scheme planning to do better in terms of means testing? And I think related to that is one participant who is asking two questions. And it begins by saying it will be interesting hearing about what the new agency will do to determine poor people's income and level of premiums. The question is one, are there any other means tested programs in place anywhere? And if so, why not just use them rather than create something unique to health sector? And more importantly, isn't it the case that everyone, including people in the informal sector, are meant to pay income tax? I think that can be answered as well by Dr. Wangia. You can take those.
Yeah, so I'll start off by touching on the issue of the transition. And yes, if you read the bill, it gives a 1-year transition period, of which a number of things, to just ensure the smooth transition from the from NHIF to the Social Health Authority. And during this time, even when it comes to the benefits by the beneficiaries, the beneficiaries will still enjoy their benefits during this period of transition as we work towards having a new benefits package and therefore new benefits for the beneficiaries. So with that, we have 1 year to, and we know that this 1 year will be adequate to ensure, a proper transition both of services to the beneficiaries and even to the providers. I think that is it. Maybe Mwai can pick up the one on the, was it contracts and claims?
Thank you very much. Let me come in on so two things. One is that the issue of outsourcing, I think it's a globally known way of dealing with claims, so to speak. But I would want us to focus on what is outsourced, because the only component that is outsourced is actually the reviewing of the claims to make sure that these claims are legit, and this is a function that is being outsourced. And if you look at the size of our country, it would be important to note that there are entities that would be better positioned to be given some certain geographic locations, which would make them more efficient in being able to verify whether that was a legitimate claim before it is actually, cleared within the system. But the issue of a pre-authorization and payment settlement, that still remains with the social authority. So what is separated actually is what is in line with the majority of the suggestions that have been made in the past in terms of policy, that it's good to have a verifier of claims and we have a payer of claims. So those are the two things that have been done within this bill that are important within the separation of functions. Now, the issue of the last question on, mean testing the poor people, I want to first highlight that nobody is suggesting, mean testing of the poor people. Even the rich people can be mean tested. So mean testing is not for the poor people, and it's a methodology that is used to determine the ability to pay. You may have very high ability to pay, and you are not poor. And therefore, please, let us get this very clear that when we talk about the mean testing, we are talking about a methodology that is rigorously well developed and well documented on how to determine ability to pay of a household. And this is done by looking at various socio-economic indicators that the household has, and use it to know what would be the lower bound ability to pay, so to speak, because the upper bound is difficult to measure. So what we measured is lower bound ability to pay. And with that, then it speaks to the fact that whether a tax-based system, whether a contributory system, all of them are based on ability to pay. And therefore, regardless of which approach we go with, I would want to highlight that the thinking behind the mixed method approach is idea that those that are informal people with ability to pay should be able to contribute. Those that actually are poor, when mean tested and they are poor, the government should be able to shoulder their contributory premiums for the contributory part of the social health insurance. And that will create a level playing ground with paid people who are payroll, who ideally are the ones that have been targeted for long, yet we know their inability to shoulder the cost of the 80 who are non-employed. So the mean testing system and tools are well classified. It's quite some laborious work, but we also know that it has not succeeded in countries that do not have community health promoters who are attached to households, and they are 100,000 in number. I mean, that is a lot. It's a volume of people that can be used in whichever manner to participate, to onboard, to convince, to do whatever need to be done to make sure that the households are able to, be enrolled, but more importantly, they access the benefits that they have been promised. Thank you.
Thank you, Dr. Mwai. Over to you, Dr. Ann.
Fantastic. Thank you very much to our panelists for responding to those questions pretty comprehensively. I know we have not managed to answer each and every question as we would have wanted to because of time constraints, but I trust that we'll continue having other platforms to engage with our panelists. We need to wrap up now. We are running out of time. I'll just give my reflections and I'll ask each of our panelists to just give their parting shots. I think you'll agree with me that there are some positive things that we are seeing from the SHI. One of them is the fact that this bill will require every single Kenyan to be a member, if you may, of the Social Health Authority. So it will be mandatory to be part of the SHI. The other positive thing that we are seeing is the 5% capping of administration costs for the SHI, the focus on primary healthcare that has long been neglected in Kenya, the introduction of other services such as or platforms to pay for healthcare, such as telemedicine, which can also expand access to primary healthcare. That said, I think there are some questions or concerns that still remain around how we will fund this social health insurance, and especially how we will collect contributions from the informal sector through means testing. So this is something that we'll have to wait and see how this will be done, given that this hasn't been done in Kenya before. Other concerns and things that we certainly need to watch out for as we move ahead around how we transition from existing schemes, from NHIF to the social health insurance. And in particular, how we make sure that we don't lose out on the gains that we've gotten from programs such as the Linda Mama program, which is a universal entitlement. Some challenges that were raised by Dr. Joy and Dr. Wangi around digitalization, claims processing, and so on, that have been quite challenging, especially for public facilities, is something that will have to be dealt with. Otherwise, we may still continue seeing a situation where public facilities, especially primary healthcare facilities, are not fully participating in the SHI program. So with those, I'd just like to hand over very briefly to each of our panelists to give us a parting shot. What would you like the audience to take away from today? What one thing should they know or expect from this SHI moving forward? Or what challenge must we deal with? Or how would you want us all to support you as you implement the SHI? Dr. Mwai.
Thank you very much. One of the things that I would want Lily to highlight to the participants as well as the panelists is one, I'll take the sentence you have mentioned on wait and see. And I'll really highlight that I would want you to become a partner in shepherding our future in terms of our healthcare financing agenda. And so I would be happy if you come to the table and don't wait and see. The second thing is that I would really think that the transition as well as the rollout of any healthcare financing infrastructure and architecture across the countries have had teething problems. And those teething problems are supposed to be addressed to enable, the system to actually stand and move forward. There are very nice suggestions within this bill. Some sounds very radical, so to speak, in terms of the thinking. But I would think that having tried the same thing and it failed several times, it's good to try a different thing now and make sure that we really have a candid discussion, genuine feedback, and therefore we will be able to move forward together and secure the financing for our country. Santi.
Thank you, Dr. Moy. I think the space for feedback and engaging further is certainly welcome. Dr. Wangia.
So from my end, I would just like to say that the bill is providing like an overall framework. However, the details on the how and what really will be captured within the regulations, and we are really looking forward at involving quite a number of stakeholders in development of the regulations, so that you can really bring in your voices on how exactly you'd want the overall framework to be implemented. So there is an opportunity, and it's until the regulations are passed that we can say that we can begin implementing the social health insurance. So we are really happy and looking forward to your engagement.
Thank you, Dr. Wangia. We will certainly be engaged. Dr. Joy?
Thank you very much to the ThinkWell team for this invite and all those who attended today, because we've had a great discussion and a great discourse, trying to highlight what the SHE brings in. But we also need to think and tell ourselves one thing. We've been journeying on the past of NHIF for very many years. What has it done differently? We need to look into the future. The future is bright. And looking at the very many other bills that are coming attached alongside the Digital Health Bill, the PHC Bill, the FIF Bill, they all play a key role and are a key ingredient to making sure that the common mwananchi attains the best healthcare. We being a devolved function, we know that mwananchi is questing for health at the very household. And these 4 bills will really be a key pillar in terms of that service delivery. We hope that the civil society that are on this call today will take up all that has been shared and share it positively out there, or even bring up more discussions that will be able to highlight the key agendas that are on the sheet, or the things that even this team has not seen that they need to amend and polish up as we move on to implement primary healthcare and the best in terms of UHC. Thank you very much for this invite.
Thank you, Dr. Joy, for offering us hope and reminding us that we have 3 other bills in addition to this SHI bill. And we also need to be engaged in ensuring that all these bills speak to one another. Thank you. Felix.
Thank you. One of the things that I would like to mention is that the basic premise for our engagement with government as partners is to support the entire process of achieving universal health coverage. The government has made tremendous progress in terms of reducing out-of-pocket payments, especially financial protection for the poor, and being able to reach the last first. And it's very encouraging to see that the folks within the Ministry of Health and within government are very open to engage and dialogue with the private sector, with civil society organizations, to ensure that we work together in this discourse. So for me, I'm pretty thankful, and I look forward to the next discussions. Thank you.
Fantastic. I just, wherever you are, please give a big round of applause to our panelists who I think have given us very insightful insights into the SHI bill. I see a hand up from Nirmala. Before I wrap up, Nirmala, do you have something that you wanted to say? Nirmala?
No, I'm sorry. I was just trying to clap and failing. Sorry about that.
Thank you. That was a very vigorous clap. But I'd really like to thank our panelists, Dr. Mwai, Dr. Wangia, Dr. Joy, and Felix for the fantastic discussions and insights that we've had over the past 1.5 hours. I think everybody who came to this webinar has left knowing a little bit more, and also with a bit of hope about what the future, what the SHI implementation is going to look like. I'd also like to thank my colleagues from ThinkWell, Carol from our communications department, Felix, Nirmala, Iliana, and Patricky for their support in helping put together the webinar and for all the work behind the scenes on the chat, just in consolidating all the questions. And finally, last but not least, I'd like to thank you all, our audience. You've been a fantastic audience. You've engaged vigorously on the chat and the Q&A platform, and we really would not have had this fantastic discussion without you. So asanteni sana, and I wish you a fantastic evening. Goodbye. Kwaheri.
Thank you so much.
Thank you, Anne,
Bye-bye.
and the team.
Thank you so much. Bye-bye.